we will discuss about an approach, how to approach children who are possibly immunodeficient. So I'll just tell you what my presentation is going to be. I'm going to talk to you about normal immunity in little detail, and then we will talk about when to suspect immunodeficiency. Then we will try to see whether we can, think about a classification of how to classify uh, immunodeficiency disorders. And then in the second half of the lecture, I'll be talking about B cell problems followed by T cell disorders. And then subsequently, we will touch upon the other defects that can cause immunodeficiency. And then in the final stages, we talk about secondary immunodeficiency states that we encounter in children. So if you talk about normal immunity, that's in children who have normal immune systems, or for us, you and me, the defense against infectious agents are usually secured through a combination of physical barriers. So we all know that skin is a physical barrier. We have intact mucous membranes, and there are also various components of the immune system. So if you look at the immune system has two main immune responses. One is what is known as the innate or the natural immune response. And the innate immune response is able to respond to infection regardless of a previous exposure. So in the first instance itself, it is the innate immune response that will come into the front line. So there are many cells that are involved with the innate immune response. You probably know that neutrophils, dendritic cells, mononuclear cells, natural killer cells are involved, and so is the complement. Now, beyond the innate immune response, we also have an acquired or an adaptive immune response. And the adaptive immune response is highly specific, and this is mainly done by the T and B lymphocytes. So if we think about how our lymphoid system develops, I'm sure all of you will remember your embryology. You start off with pluripotent hemopoietic stem cells, and these are present in the yolk sac by about 3 weeks of intrauterine life. Then the cells will start to migrate to the liver by about 5 weeks, and then they further migrate to the bone marrow. So in the developing fetus, we have primary lymphoid organs, which are the thymus and the bone marrow, which starts to produce lymphoid tissue by the first trimester. And then soon after, you see that secondary lymphoid organs like the spleen, lymph nodes, tonsils, and the Peyer's patches will start to develop. Now, all these sites, the primary lymphoid organs and the secondary lymphoid organs, will act as sites for differentiation of T cells, B cells, and the natural killer lymphocytes. Now, what is immunodeficiency? Immunodeficiency is a state that results due to absence or failure of normal function of one or more elements of the immune system. So there is either a total absence of one section, or it may be multiple, or there is a failure of normal function. Although the cells may be there, they may not be functioning normally. So basically what it would do, it will cause an increased susceptibility to infections in children. So depending on the specific defect of the immune system, it will have a bearing on the type of infection that patients may get. It will also predispose to different types of pathogens. So the type of infection might be a viral infection, more tendency to get bacterial infections. So if you are thinking about pathogens, you might see intracellular pathogens, extracellular pathogens, so on and so forth. And also, what may also happen is that it may allow infection by organisms that would usually not succeed in causing infection in a child or person who has normal immunity. And these pathogens, I'm sure you remember, are known as opportunist pathogens. Then what else could happen? It could also lead to multiple infections, which can happen more often. And it may also lead to dormant or infections which are laying dormant in the body, or latent infections to activate. So when it comes to clinicians like you and I, one of the main concerns that we would have is whether a patient is actually immunodeficient. Because in normal clinical practice, I'm sure you see many patients who are admitted, sometimes with recurrences of infection. Sometimes they come with recurrences of fever. We see them in clinics. And one of the common questions that sometimes parents do ask us is, Doctor, do you think my child has normal immunity? Do you think he needs an immuno boost? Because parents do think that sometimes with vitamins and so on, you may get a so-called immuno boost, which I actually doubt. So, first of all, now, if a normal child may actually have up to 10 to 12 upper respiratory infections per year. So basically, they could have one upper respiratory infection, which may be associated with fever, which may actually settle without any specific treatment. And that is not because they are immunodeficient, that is normal. So when you have a patient who is actually immunodeficient, you know that they are going to be susceptible to recurrent infection, and as a result of that, it's going to lead to use of multiple antibiotics. They're going to stay in hospital for a long period of time. It's going to have effects on the family and the siblings. It leads to added financial burden. It's not only for the family. In a country that provides free healthcare, the financial burden is huge. I'm sure all of you see how much of local purchase of so-called broad spectrum antibiotics are done when we can't manage things with the conventional antibiotics we use. And you try and get the patient under control, send them home, and they are back maybe in a week or two with another recurrence or a new infection. We also have difficulties in confirming diagnosis because sometimes in the, you send samples but you don't get reports, or sometimes patients are unable to afford certain tests, and in spite of doing all this, you know that it is going to lead to poor outcomes sometimes. So it's a very challenging thing for a clinician to manage a patient with immunodeficiency. So let's see how we move on. And now if I try to categorize the immunodeficiencies, we can have two main broad categories. We have what are known as the primary immunodeficiencies, and the primary immune deficiencies are due to intrinsic defects in the cells of the immune system. So we know that we discussed about the cells in the immune system. We have T cells, we have B cells, and there are of course many other cells like neutrophils and so on, which play a part in immunity. So there are intrinsic defects in these cells. Most of them are genetically inherited, and majority of primary immunodeficiencies are encountered in children. Now, if there is a primary category, obviously there has to be a secondary category. And the secondary immunodeficiencies are due to acquired immunodeficiency states. We see patients who are malnourished being immunodeficient. If you have significant burns, you are likely to become immunodeficient. We see a lot of patients who are immunodeficient because of associated malignancies or following malignancy. They are on either irradiation or on cytotoxic drugs. And the irradiation, the malignancy per se, or the cytotoxic drugs can make children immunodeficient. And then, of course, we have acquired infections like HIV and TB that will lead to secondary immunodeficiency. Now, compared to the primary immunodeficiencies, the secondary immunodeficiencies are encountered both in children and adults. So now, when do we suspect immunodeficiency? There are certain guidelines that have been given and which have been developed over time. So we will just go through them. I'm sure this is sort of common ground for you. I'm sure you have already managed patients with immunodeficiency. So this will perhaps refresh your knowledge. So if a patient has one or more systemic bacterial infections, for example, sepsis or meningitis, then you may have to consider whether the patient could be immunodeficient. Having two or more than two serious respiratory or documented bacterial infections within a year. The documented bacterial infections could be things like cellulitis, abscesses, and lymphadenitis. If you see serious infections occurring in unusual sites, say you have a patient coming with a liver abscess, or they're coming with recurrent abscesses involving liver and brain. We don't usually see such patients. So, serious infections occurring in unusual sites, and also infections with unusual pathogens. You know, we have straightforward pathogens who cause illness, but if we see patients who are getting illnesses either because of pneumocystis, aspergillus, serratia, nocardia, burkholderia, then those would be the more uncommon pathogens. And that also is one of the reasons where you should suspect immunodeficiency. Then, of course, you might have infections with common pathogens, but with unusual severity. So if you have a patient with, Streptococcus pneumoniae and he's not getting better but getting worse, or you have significant mycobacteria infection in unusual severity, HSV, Epstein-Barr virus, then that is again one of the things to worry about whether the patient could be immunodeficient. They can also present with failure to thrive, that is, they are not gaining weight adequately, and not gaining weight adequately either may be associated with an ongoing diarrheal illness or it may happen without a diarrheal illness. They can sometimes develop infection following live vaccines, and the live vaccines that they can develop infections is things like BCG, which is done in our country, but if you go to the West, BCG is not a mandatory vaccine, and the live vaccines that they would get would be the mumps, measles, rubella, and patients may develop infection with such vaccines. They can also present with chronic oral or systemic candidiasis. And then, of course, because there is a genetic background to most of the primary immunodeficiencies, a positive family history is another, indicator that a patient might be immunodeficient. So now that we have discussed two broad categories, the primary and secondary immunodeficiencies, and then having gone through when to suspect immunodeficiency, now we will try to classify the primary immunodeficiencies. So the primary immunodeficiencies, there are again three broad categories. There could be defective cell-mediated immunity, and that is mainly disorders related to the T cell. There could be defective antibody responses where the primary problem will be with the B cell. And then, of course, you can have defects in non-specific immunity, which involves the complement system and neutrophils and so on. Now, although we can classify this way, in a clinical setting, I believe classification according to the age of presentation might be the more useful thing. So, having listened to my presentation, I'm sure you will be able to, at the end of this, probably think these are the ones that are likely to present early, these things will present somewhat later, and these things are going to present even later. So let's see whether we could, think about such a classification little later on. Right. Now, we'll talk about the B cell disorders, and to talk about B cell disorders, I thought we will just talk a little bit about the physiology of development of B cells. Now, B cells differentiate from what are called primitive B cells, and the earliest stage is known as a pro-B cell. And the pro-B cell will then move to what is known as a pre-B cell, and then to an immature B cell, which will eventually differentiate into a mature B cell. Now, in antigen-dependent stages, the mature B cells then are stimulated by antigens, and they will then become memory B cells and plasma cells. Now, if you look at the immunoglobulins and about the antibody-mediated immunity in a small child, I'm sure you all know that it is only IgG that is able to cross the placenta. And transplacental transfer will occur after about 30 weeks of gestation, and it is usually complete by term. So, more the preterm the baby, then it is likely that they are likely to have less amount of maternal immunoglobulins transferring to the fetus, and I'm sure you know that the preterm babies are at risk of sepsis because of this reason. Now, whatever that goes through the placenta then will start to decrease, and usually the maternal immunoglobulins that are received through the placenta will go down to very low levels by about 4 months of age in the infant. At the same time, after the infant is born, they will be getting exposed to different antigens, and therefore the baby will start to develop an IgM and IgG response slowly from birth, and the full complement of IgG is reached by about 3 years of age. Then, of course, we also have something called IgA, which is the major antibody in bodily secretions, and that is found in tears, saliva, breast milk, and sweat. So, we will now move to the primary B cell deficiencies, and I've listed down 5 primary B cell deficiencies. There is what is known as X-linked hypogammaglobulinemia, common variable immunodeficiency or CVID, IgA deficiency, IgG subclass deficiencies, and immunodeficiency with increased IgM levels. So in the next few minutes, I will be talking about 3 of these conditions, the first 3, because they are actually the common ones, and I think it's important to have some sort of background knowledge about them. So let's start with the agammaglobulinemia. It's also called Bruton's disease. So it is X-linked, so obviously males are affected. Incidence can vary from about 1 in 10,000 to about 1 in 50,000 in different parts of the world. And this is mainly caused by a defective B cell protein called tyrosine kinase. I'll show you a picture in a moment. So because of this defective B cell protein, these patients who are agammaglobulinemic have very few or no B cells in their blood or lymphoid tissue. So if there are no cells in the lymphoid tissues, they tend to have very small lymph nodes. They are likely to have absent tonsils. And if you do their serum immunoglobulin levels, their serum immunoglobulin levels for IgA, IgM, D and E will be almost absent, and they may have very, very low IgG levels. So this is what happens. You see that we spoke about the pre-B cell and the pro cell, and the change from the pro-B cell to the pre-B cell doesn't happen because of the BTK deficiency. So this is where I have shown you with a cross where the defect is, and this is what leads to the gamma globulinemia. So now these patients, they are usually protected for the first 6 to 9 months of life. Now you know that maternal immunoglobulin is transferred through the placenta to the baby. I said that the levels become very low by about 4 months. But however, most patients are generally protected up to about 6 months. So the patients who have B cell problems are likely to present when the maternal immunoglobulin levels are going down. So the ones with X-linked A-gamma globulinemia, they tend to get recurrent infections due to extracellular pyogenic organisms. The common examples are strep pneumoniae, Haemophilus, and staph. They can also develop infections with mycoplasma. These patients are generally able to handle viral infections well. However, they are more prone to hepatitis and enteroviruses. The infections they have are usually what are called sinopulmonary infections. So they tend to have sinusitis, they can have otitis media, and they can have pneumonias. They are less likely to have sepsis or meningitis. So this is just to elaborate a very severe pneumonia in a patient with A-gamma globulinemia. You can see that the pneumonia, probably starting off in the lower lobe, has now extended to the middle and almost the upper lobe. Right. So what do we see in their examination? So they are likely to have lymphoid hypoplasia. So as I said previously, lymph nodes may not be palpable. There may be absent tonsillar tissues. So in a patient who probably presents to you beyond 4 to 5 months with maybe recurrent pneumonias or they have recurrent otitis media, then you may have to consider whether they could be having A-gamma globulinemia. So your clinical examination will be useful. And then if you do have suspicions, then it is good to undertake to do the serum concentrations of immunoglobulins. Now, it's very important when you have a patient with an underlying immunodeficiency to liaise with the institutes that do these so-called tests. The MRI is generally very helpful. We have a very helpful immunologist. So it's good to have discussion, maybe discuss your patient, and then he would generally give you idea about what investigations to send. And so there's no point only sending the investigations. I think you need to sort of make sure that you get a response and you get the results back. So your serum immunoglobulins will be very low. Then you could also measure the antibody response to the normal immunizations that are given. So you might be able to check and see whether the patient has developed antibodies against the diphtheria, tetanus, pertussis vaccine, which is administered at 2 months, 4 months, and so on. So if they have not developed antibodies, that goes to say that there is defective antibody response. There is also possibility for you to undertake what are known as the isohemagglutinin levels. That is to check whether there is anti-A or anti-B in the patient. Now, when you have to check whether there is anti-A or anti-B, I'm sure you would understand, you can do it only if you know that the patient's blood group is O, A, or B, right? So in a patient who is AB, there is no point checking anti-A and anti-B because they usually would not have it. Then if you go a little further, you can do flow cytometry, and in the flow cytometry, you can look for specific CD antigens, CD19 and 20. So what happens to these patients? They can be usually successfully treated if you treat them very, aggressively. And you have to start, once you've made a diagnosis, you have to start them on immunoglobulin replacement therapy. And the immunoglobulin replacement therapy is usually going to be lifelong. And not only that, it will be life-saving. You have to be aggressive when you have patients with X-linked A-gamma globulinemia getting infection. So you may have to actually use immunoglobulin even during the critical phase, and then also use broad spectrum antibiotics. Some of them can be started on prophylactic antibiotics. If they are developing recurrent sinopulmonary infections, there may be a place for use of prophylactic antibiotics. Now, your immunoglobulin doses also have to be titrated to ensure that the patient is getting sufficient amount of immunoglobulin. So you are expected to do trough levels of immunoglobulin, and then you can compare it with the normal levels that the patient should have, and if it is below what is normal, and then you may have to jack up the amount of immunoglobulin that you would be giving the patient. Right. Having done that, we will now move to another entity, and that is called common variable immunodeficiency. And this is known to happen due to multiple genetic defects. So it could be, inherited either in an autosomal recessive pattern or in an autosomal dominant pattern. The sex distribution is equal as opposed to A-gamma globulinemia, where it was predominantly seen in the males. And this is another instance where there is characteristically you have hypogammaglobulinemia. That means you have low levels of immunoglobulin with phenotypically normal B cells. So in the first instance, we didn't have B cells. Now you have phenotypically normal cells and low immunoglobulin levels. Now, what happens here is that the cells don't differentiate normally into immunoglobulin producing cells. And as a result of which, here, depending on the genetic defect and the severity of the illness, the age of onset can be reasonably variable. So they tend to present a little later. However, the type of infection and the bacterial etiologies are similar to those with X-linked A-gamma globulin. And although the etiologies are similar, the infections are, of course, less severe in intensity. So what do they get? They also tend to get the same sort of illnesses. They can have recurrent pneumonias, sinusitis, otitis media, and they can also present with diarrheal illness. And the etiology for the diarrheal illness could be bacterial etiologies like maybe E. coli or Shigella, and they can also get diarrhea due to giardia. Now, if these patients tend to get recurrent or repeated pulmonary infections, that may lead to bronchiectasis. Compared to the X-linked A-gamma globulinemia, CVID patients have a tendency to form autoantibodies, and their tonsils are normal or they may be enlarged, and they also do have lymph nodes, and about 25% of patients with CVID will have associated splenomegaly. They can have other associated phenomena. They can have thymomas, they can present you with alopecia, they can have hemolytic anemia, pernicious anemia, lymphoid interstitial pneumonia, and they will, of course, be also at a risk of developing lymphoreticular malignancies like lymphoma. Now, if they do get sepsis and meningitis with encapsulated bacteria, you would generally see it happening more frequently than in the normal population. So how do we diagnose CVID? You would tend to have low serum IgE levels ranging from fairly low levels of less than 100, and it might be just above the normal adult range. So they tend to be on the lower side. You see that in the previous entity that we discussed, immunoglobulins were barely not present. Here you have very low levels. So here again, treatment will be with IVIG and aggressive treatment of infections. Right, we are moving to the third entity, which is of course the commonest primary immunodeficiency. That is the Iga deficiency. It has an autosomal dominant inheritance and it has variable expressivity. So therefore, some patients may be completely asymptomatic, whereas some patients might have recurrent infections, or like in CVID, they can develop autoimmune disorders, and some patients with IgA can sometimes develop CVID over time. Here the issue is the failure of the terminal differentiation of the B cells. So if you have a total IgA deficiency, your IgA levels can be as low as less than 5 milligrams per deciliter. So how do they present? Depending on the severity of infection, some of them could be asymptomatic or have mild symptoms. They too tend to have recurrent sinopulmonary infections. They can have GI infections with giardia, and sometimes they can have a disease somewhat similar to celiac disease, but which doesn't respond to a gluten-free diet. And similar to the CVID, they too have a higher incidence of autoantibodies, autoimmunity, and the risk of malignancy. So administration of IVIG is not indicated in IgA, although it was indicated in the previous two entities. So for B cell disorders, we have spoken about X-linked A-gamma globulinemia, CVID, and IgA. For A-gamma globulinemia and CVID, we would use IVIG, but in IgA deficiency, we don't generally consider IVIG. So having finished that, now we will move to T cell problems. And T cell problems, or patients who have T cells, either they could have no T cells or they could have poor T cell function. And as a result of that, they become susceptible to opportunistic infections. Now, you must, if you remember the pluripotent stem cell and how it differentiates, you will recall that the development of the B cell is largely dependent on the T cell, mainly for its maturation and function. So, if a patient is T cell deficient, then obviously what would happen is that the patient will end up with a combined immunodeficiency because the B cell maturation and function is dependent on the T cell. So these patients are likely to have more severe illness and their symptoms will be very severe. They are prone to viral, fungal, protozoan and TB infections. We see them having significant failure to thrive, and in some instances, T cell deficiencies can be fatal in early childhood, right? So this is to show you how a patient with a T cell deficiency has got, I said they are more prone to viral, fungal, opportunistic infections. Here, having disseminated varicella. Here is another patient with a T cell deficiency having a full-blown bronchopneumonia, which is not responding very well to the treatment that is being used. And I'm sure you can appreciate that this is a patient who is having features of systemic candidiasis. Right. So primary T cell deficiencies, there are few entities. We will try to discuss some of them. There is what is known as severe combined immunodeficiency, which is also called SCID. There is DiGeorge anomaly, ataxia, and Wiskott-Aldrich. There are, of course, many more, but these I would think are the more common things. So therefore, I will probably be discussing in detail about some of them. Right. So severe combined immunodeficiency, as its name stands, is the most severe one, and it is known to result from mutations in more than 15 genes. And because of the mutations, there is molecular defects which will interfere with the development of lymphocytes and their function. There could also be a block in the differentiation and proliferation of T cells, and in some of the deficiencies, there could be interference of B cells and natural killer cells as well. So these are inherited in autosomal recessive fashion in about 50%, and there is another 50% which are X-linked recessive, right? So there are wide variety of genetic disorders which cause SCID, right? So I've just put down a table for you, just for your information. I don't think it is possible for you to, know this in detail. If you just go on the web and type SCID, then you might be able to see the full table. So here you can see that many of them are autosomal recessive, and the different disorders, they talk about which parts of things are affected. You see that in reticular dysgenesis, you have T cells, B cells, NK cells all being affected. But in some of the other entities, maybe one or two groups of cells may not be affected. Usually present within the first few months of life. As I said previously, they have significant failure to thrive. They can have multiple infections of different sites, and usually without intervention, they are likely to die. So SCID is considered a pediatric emergency because survival will depend on early stem cell or bone marrow transplant. So it's important to try and diagnose them early, and of course think about whether there is possibility of a bone marrow transplant. So what organisms cause illness in patients with SCID? We said they are more prone to viral, fungal, and opportunistic infections. So Candida is known to cause systemic illness. They are more prone to pneumocystis pneumonia, adeno, RSV, CMV, EBV. They can all cause florid infection in such patients, and so could the varicella virus. They can have illness because of vaccines, and the MMRV, which is given in the West, is known to cause illness in them, and so is the BCG. And the diarrheal illness they have is usually caused by either Giardia or Cryptosporidium. This is a patient with the severe combined immunodeficiency, and this was taken from the Italian Journal of Pediatrics. And again, showing another picture of a patient who has developed bronchopneumonia. So In patients with severe combined immunodeficiency, one of the key things is that you may not identify a thymus, they have absence of lymphoid tissue, and one of the other key things is that these patients are lymphopenic. So if you do a full blood count, you will see that the percentage of lymphocytes they have is on the lower side. You know that until 4 years of age, all children tend to have more lymphocytes in their blood as opposed to neutrophils. And it is after 4 years that you have the normal adult constitution of the neutrophil to lymphocyte ratio. So to see a patient coming with, very florid infection, and you do a full blood count and you see that the lymphocyte count is on the lower side, then of course you may have to wonder whether this patient could be having SCID. There is also a reduction in the T cell population and CD4 helper cells because I said that T cells have a bearing on the B cells. They have decreased serum immunoglobulins and they will most likely need a bone marrow transplantation. During the interim, things that we could do is to perhaps treat the infections very aggressively. If you think that they are more prone to, pneumocystis or fungal infections, then there is a place for prophylaxis with amphotericin or cotrimoxazole. There is also a place of using immunoglobulins intermittently. With all this and what has been said, live vaccines will obviously be contraindicated, and if you are planning to use blood product, please try to use irradiated blood products on patients with suspected immunodeficiency. We move to the next disorder, and that is Wiskott-Ulrich syndrome, which is an X-linked recessive disorder, so basically affecting males. And this, again, the variability of the clinical disease will depend on the mutation within the WASP gene product. And these patients will also typically present within the first year and within the first 3-4 months with severe persistent thrombocytopenia, eczema, recurrent sinopulmonary infections, or opportunistic infections. The sinopulmonary infections they are likely to have would be things like otitis media, pneumonia, sepsis, and meningitis. They can get opportunistic infections with pneumocystis, and sometimes if patients develop viral infections, they can have very severe disseminated viral infections like herpes simplex and varicella. So here again, we see that there is some amount of autoimmune disease that may be present in patients with Wiskott-Ulrich. They have an increased risk of lymphoreticular malignancies. So things like lymphomas, leukemias, and myelodysplasia are likely. And in such patients, if you do manage them, you will have to serially screen them to see whether they are developing any of these, because we just mentioned in the initial part of the lecture that some of the malignancies by themselves will give rise to a secondary immunodeficient state. So like any other immunodeficiency, they will require vigilant general medical care, prompt and aggressive treatment of infections, and of course bleeding. And here again, there is a place for IVIG therapy. Right. To go to the next anomaly, which is DiGeorge anomaly. And here is a problem that leads to a defect in the thymic embryogenesis, leading to hypoplasia of the thymus. Males and females, both parties affected, and it is known to happen due to microdeletions of the chromosome 22. Now, patients with DiGeorge have very, very distinct facial features. They have hypertelorism, low-set malformed ears, sometimes micronathia, sometimes a carp-shaped mouth. They might have a short philtron and a cleft palate. So if you see these, then you need to think about, say you have a patient coming with cleft palate with recurrent pneumonia, it may be because of aspiration. But then if the other facial features are there and you have also associated congenital heart disease like either a truncus arteriosus, VSD, interrupted aortic arch, maybe you should think about diGEORGE. And the facial features may not be very obvious in the initial phase, but as the child grows, these things become more obvious. And if there is a significant defect in the third and fourth pharyngeal pouches, they are likely to present with hypocalcemic seizures much before the immunodeficiency, and that happens because of the absence of parathyroid glands. So if your history is that the patient has been managed for seizures and then subsequently coming in with early onset infection, then it is high time to think about diGEORGE. 1/3 of these patients with diGEORGE can also have a what is known as charge association. I'm sure you know what that is. So these are two photographs showing you how patients with diGEORGE can look like. One is rather old, the other one is quite young, and I believe that you would sort of appreciate the low set ears, the carp-like mouth, the small philtrum, and so on and so forth. Right. So what does diGEORGE do? It leads to a reduction in the circulating lymphocytes. The B cell functions are intact and therefore they have normal immunoglobulins. And children with partial thymic hypoplasia, and they might actually grow as normal children. They might get infections, but with infections, if you treat them, they can actually grow up to be normal children. But the ones who have got complete diGEORGE, they are again susceptible to similar infections as in T-cell disorders, viral, fungal, and parasitic, and they can also sometimes develop graft versus host disease. So the definitive treatment would be to think about a thymic tissue transplant for them. So ataxia telangiectasia is another illness where you might get patients presenting to you with ataxia maybe from about 3 to 4 years of age, and then subsequently they also can develop recurrent infections, more so because they too have problems in their T cells. So the next entity that I will talk about is hyper Ige syndrome. Not very common, but again giving rise to primarily both T cell and B cell problems. So it is acquired in an autosomal dominant manner and a recessive manner. So these patients have got very coarse facial features. They've got prominent foreheads, deep set widely spaced eyes. They can have a broad nasal bridge, and what is very characteristic is the fleshy nasal tip, which I will show you in a minute. And the older children they can present with delay in shredding of their primary dentition and recurrent fractures. So this is a photograph of the same child. You can see the years being mentioned, 2012, 15 and 16, and you see that the tip of the nose is quite fleshy, and the deep set eyes and so on. And lower down, what I've tried to show you is that the primary dentition is still present in spite of the secondary dentition being unable to erupt. So these patients have recurrences of staphylococcal infection, skin, and also they can have abscesses involving staphylococci involving lungs and joints and other viscera. They can also have sinusitis and mastoiditis, which is caused by candida. So they have a very high, exceptionally high IgE level and IgD levels, and in the blood they have pronounced blood and sputum eosinophilia. So during my training, I had the opportunity of seeing one of these patients, and well, all the characteristic findings were present in this patient, and this child had been treated for recurrent skin infections very early on in life. And in my first year as a registrar, I saw this child in Ratnapura, where by that time, we were thinking that this child could have an immunodeficiency, and then we made this diagnosis of hyper IgE. Right, defects in phagocytes. So phagocytes, are the first line defense. So now basically I finished with the T cell disorders, and now we are going into the non-specific immune response causing cells. So neutrophils are the first line of defense, against microbial invasion. And neutrophils can be, the problems related to neutrophils could be either a problem in relation to quantity or in relation to quality. Okay, and the defects in neutrophils can give rise to overwhelming infections. And the presenting signs and symptoms will obviously overlap with other immunodeficiency disorders. So they are likely to present with deep tissue infections, pneumonias, adenitis, and osteomyelitis. So leukocyte adhesion deficiency is fairly common. I may have seen about 10, 12 patients in my career. Autosomal recessive inheritance. The main problem with the neutrophils is that they are defective in adhesion, they are unable to move, and they are unable to phagocytose the bacteria. So basically, they can't get to the site of infection. And even if they get to the site of infection, there is failure of recognition of the microorganisms which are opsonized with the complement. So these patients can present fairly early, and they present with soft tissue injuries and infections with absence of pus. It should be soft tissue infections. Sorry about the typo there. And what is common is that they have a significant finding of granulocytosis. So they have very, very high white cell counts. And if you go back in the history, you will find out that there has been a delay in the separation of the core. So they can come with redness in relation to the umbilicus even after the fall of the umbilical stump has been delayed. And they get recurrent infections of the skin, the mouth, the respiratory tract, and genital tract. Organisms that can cause infections include Staphylococcus, E. coli, Candida, and Aspergillus. So because there is no pus formation, the typical signs of inflammation may be absent. So you may not see swelling, redness, and vomit, but the patient might be having fever, and you do their total white counts, you will see that they have a significant neutrophil leukocytosis. And even during the time these patients don't have infection, their total white cell counts can be higher than 25,000 per liter. And they can actually go even higher during times of infection, up to even 48, 50,000. So diagnosis is established by flow cytometric measurements, and for such patients, it is an allogenic hematopoietic stem cell transplant, which will be curative. I've been unfortunate to actually see maybe 3 families where more than 2 siblings have been affected, and unfortunately none of them were able to survive. We made diagnosis, but they succumb to infection. So before I go to chronic granulomatous disease, in relation to the neutrophils, you can have another entity called congenital neutropenia, which is also known as Kosman syndrome, where the number of neutrophils are congenitally very low. And there is also another entity which is known as cyclical neutropenia, where the number of neutrophils in the body tend to go down to low levels over periods of cycles. And these cycles generally tend to be about 3 weekly. And during the time that the neutrophil count goes down, such patients with cyclical neutropenia tend to become more susceptible to infections. So you might see them getting admitted on a regular basis when their neutrophil counts are going down. So the next entity is chronic granulomatous disease, and it is about 65% X-linked and 35% autosomal recessive, so which means that girls and boys can both be affected. It is due to an abnormality in the NADPH oxidase. So here what happens is that the neutrophils are unable to produce the superoxide radicals, which are useful for ingestion of microorganisms. These patients also will present with recurrent skin infections and infections of the lymph nodes with abscess formation in the first year of life. And they can also develop pneumonias with lung abscesses and empyema. That's to show you, multiple abscesses. And patients with chronic granulomatous disease can also have osteomyelitis involving the small bones, and they can have hepatic and perianal abscesses. They can also get chronic diarrhea, and if because of the granuloma formation, and that could lead to obstruction involving the gastric antrum, ureters, and sinuses rarely. So if you are investigating a patient with chronic granulomatous disease, we undertake what is known as the nitrobrew tetrazolium test, and this reagent is colorless, and when the NBT is reduced, it turns out to be deep blue color. So if you have a negative NBT test, that will favor a CGD. They have raised immunoglobulin levels, and here again, the treatment is with aggressive treatment of infections and sometimes use of cotrimoxazole prophylactically, and then of course thinking of a bone marrow transplant. So this is a patient with chronic granulomatous disease, and in the right hand side, the top one, you see that the picture is fairly purple in color, and in the lower down, that's the patient's slide because the test is negative, and in the lower slide you see that the test is positive, and you see the bluishness because of the reduction of NBT. So complement deficiencies can also give rise to infections. C1 and C4 leads to infection with encapsulated bacteria, Haemophilus and Streptococcus. It has also increased risk of connective tissue disorders. C5 and C9 components can give rise to Neisseria sepsis. And complement deficiency is treated with antibiotic prophylaxis, vaccination, and aggressive treatment of infection. So let's quickly go through with the secondary immunodeficiency. I won't take too long. We said secondary immunodeficiencies can happen because of malnutrition, underlying malignancy, which have been treated either with irradiation or cytotoxic drugs, and with burns. So this is a child with burns, and they can be susceptible to significant infections. I'm sure you have seen patients with burns getting multiple infections. So aggressive management of burns and infections become very important. We know that we use multiple drugs for various disorders, and the drugs themselves can cause a secondary immune deficiency. One of the well-known drugs to cause secondary immunodeficiency are steroids, because they usually affect cell traffic, they induce a leukocytopenia, and they inhibit the synthesis of cytokines. And they can also inhibit T cell activation and proliferation. We use large amount of corticosteroids for various illnesses, some of the chronic nephrotics, and patients with the connective tissue disorders are on high-dose corticosteroids. Then when we also use other disease-modifying drugs and immunosuppressants like cyclophosphamide, azathioprine, MMF, and methotrexate for various other disorders. When we use these drugs, we are likely to make these patients immunodeficient. And therefore, whenever they come with fever, I think you need to be very aggressive in their management. Again, undernutrition, again known to cause immunodeficiency because infection and malnutrition usually aggravate each other. So it is well known that protein energy malnutrition will cause reduction in cell-mediated immunity. They reduce the number of CD4 helper cells, and they also lead to trace element deficiency. And when you have deficiency of iron, selenium, copper, and zinc, this can lead to diminished neutrophil killing. So undernutrition is another entity that you need to be concerned about. I'm sure some of you have seen patients who are admitted with severe acute malnutrition. So such patients could be at risk of infection. So the last entity that I will be talking about is HIV. And don't think it is not uncommon. It is not uncommon. We are probably seeing only the tip of the iceberg. There are many patients, or at least adults, could be infected, and they might be infecting their children through mother-to-child transmission. So it's important to think about, if you can't think about the primary disorders and you have patients, very young children who are not responding to treatment, who are not showing the normal response to treatment, getting admitted frequently, think about HIV as well. So in the latter half, we have discussed about the secondary immunodeficiencies. In the first half, we discussed about the primary deficiencies. So I think it's time to stop, and I would like you to consider immunodeficiency in the differential diagnosis in patients who are not responding well to treatment. You need to use your first line investigations to narrow down your differential diagnosis. So taking blood cultures, doing full counts, CRPs, ESRs, those are very important because the blood cultures themselves sometimes will be useful for you to differentiate what organism is causing the infection. And then if there is any doubt or you think that immunodeficiency is a possibility, always try to request for the appropriate confirmatory investigations. You can liaise with the immunology team for such information, and you can then pick on the right test. Try to send the samples on maybe weekdays so that the samples don't remain on desks and they don't get done or they are thrown away because they are not appropriate to be handled. And once you have suspected immunodeficiency, it's very, very important to manage these patients aggressively until you have a diagnosis established. So regular follow-up, prophylactic medication, use of IVIG will certainly improve the outcomes of some of the immunodeficiencies. Thank you very much.